I'm Kevin Bobrowsky. I'm from Kaiser Permanente Vallejo. I'm a cardiologist, and I'll be discussing cardiac rehabilitation, its role in a STEMI program. I have no relevant disclosures. This presentation will discuss the definition, the role, and the importance of a comprehensive cardiac rehabilitation program. Topics covered will include the benefits of exercise and risk reduction for secondary prevention and improving our patient outcomes, including a discussion of the components of an exercise prescription for our coronary artery disease patients. Hopefully you'll have a better understanding of cardiac rehabilitation for STEMI patients and understand what goes into an exercise prescription for STEMI patients after this presentation. Well, it's been said by Benjamin Franklin, among others, that an ounce of prevention is worth a pound of cure. Most of our coronary disease patients and most of our patients coming into the cath lab for STEMIs are it's a new diagnosis. They have been neglecting, a lot of aspects of their health, their diet, high blood pressure, diabetes, etc. They get treated for a heart attack, the arteries opened, and then the real work starts in terms of how can we keep them healthy, how can we improve their overall outcome with secondary prevention. So that's where cardiac rehabilitation comes into play. It's many aspects. It's not just exercise, but it's all of these multidisciplinary approaches, efforts to improve lipid management, blood pressure, treatment of diabetes, getting our patients to quit smoking, identifying psychosocial conditions, depression, for example. Identifying and treating these conditions will have a big impact. And then, we focus on how can we get our patients to get healthier. Diet management, nutrition counseling are very important. And then exercise training. This is where this is the cornerstone of cardiac rehabilitation. Just a little historical perspective, it's interesting to note that way back in 1772, with the original description by Heberden of angina, he described how he had a patient with angina pectoris who set himself a task of sawing wood for half an hour every day and was nearly cured. Unfortunately, the concept of exercise in the setting of a heart attack was the direct opposite of that approach. In the 1930s, the standard of care was prolonged bed rest. This improved somewhat over the years until finally during the 1960s with coronary care units and a lot of research, it led to our current multidisciplinary approach. The CR program is evolved into 4 phases. The inpatient phase is phase 1. It's important to start this process early with patient education and initial rehabilitation. After the next day after an intervention, we try to get our patients up out of bed, moving around, have them ambulate. We usually are keeping our STEMI patients 1 or 2 nights after, depending on if it's uncomplicated MI. But our initial approach leads to phase 2, which is the individualized exercise prescription as an outpatient and a focus on risk factor reduction. Hopefully this will lead over time to independent behavior change and continued exercise independently, the so-called phase 3 and 4 maintenance phase of cardiac rehabilitation. Which patients should be referred? Well, any patient who has been treated for a STEMI or a non-STEMI in the prior 12 months is a candidate. This also includes patients with chronic stable angina pectoris, percutaneous intervention, elective cases, also includes peripheral cases, and our patients after bypass surgery or even after valve replacement. These are also patients for whom cardiac rehabilitation is appropriate. Also, clinically stable heart failure patients also benefit from a cardiac rehabilitation program. The efficacy of CR programs is well established in patients with CAD. Meta-analysis done in about 8 to 10 years ago demonstrated a reduced rate of reinfarction among myocardial infarction survivor patients with a cardiac rehabilitation program. Also, there was a reduced mortality, not only cardiac, but all-cause mortality. You can see this from this forest plot of all the different studies looked at in the meta-analysis here. The intervention, the fact that it's to the left favors the intervention, and you see the majority of the studies showed a significant reduction in reinfarction among MI survivors. Similar plots show the effect of exercise-based CR on reducing cardiac mortality among MI survivors. And here's another one showing reduced all-cause mortality among myocardial infarction survivors. The benefits of participation in exercise-based cardiac rehabilitation is also associated with greater improvements in blood pressure, lipids, rates of smoking. There is also decreased hospitalizations, reduced anginal symptoms, and reduced depression. Also improved exercise performance and health-related quality of life. So all of these aspects have been attributed to and found to be benefits of an exercise-based cardiac rehabilitation program. What are some additional benefits? Well, as referring physicians, we get ongoing valuable surveillance. We find out, sometimes we learn of arrhythmias that are occurring, either a heart block or atrial fibrillation. We may discover that our patients have developed new symptoms of angina, which maybe we wouldn't have heard about otherwise. And we can hone in more on hypertension management and find out if they're developing any possible symptoms of heart failure. Here are some important concepts to keep in mind in terms of physiology. The age predicted maximal heart rate, 220 minus the age is how we calculate it. The VO2 max, this is the highest rate of oxygen use that can be achieved at maximal physical exertion. We also have the VO2 peak, which is the rate of oxygen use at symptom limited peak performance, which is lower than the VO2 max for most adults. A MET, one metabolic equivalent, is essentially what your the amount of energy expended at rest. And vigorous exercise starts around 6 to 7 METs. In terms of exercise hemodynamics, it's important to realize that heart rate increases linearly and then it plateaus. And then you reach a steady state maximal heart rate. A similar finding happens at the VO2 max. Stroke volume, however, increases in a curvilinear fashion. And remember, stroke volume is the result of an increase in the chamber left ventricular end diastolic volume and a decrease in the LV end systolic volume. So you get an increased cardiac output as an effect of an increase in the stroke volume and the heart rate. Cardiac output is the stroke volume times heart rate. So you get an increase from levels of about 5 liters per minute up to around 20 to 25 liters per minute with exercise. During exercise, the blood pressure in men, if it's above 190, and in women above 170, we consider that to be a hypertensive blood pressure response. We usually don't see much of a decrease in the diastolic blood pressure. It may decrease or slightly or remain unchanged. Okay, moving on here, the maximal oxygen consumption, the VO2. This is the most widely used and accepted criterion of cardiovascular fitness. It can be calculated with different calculations. We have invasive VO2 exercise testing, but most of the time we're not calculating the VO2 max. Most patients, as mentioned, reach a point of fatigue and discomfort well below their physiologic maximum. Therefore, a symptom-limited performance or VO2 peak often is less than the physiologic VO2 max. So the exercise capacity of VO2 max exerts a major long-term influence on prognosis in men after myocardial infarction, bypass surgery, or diagnosed with ischemic heart disease. This was shown in this study in Circulation of 12,169 patients referred for cardiac rehabilitation. And you can see quite a difference in survival among the different strata of VO2 max. So you can see from the highest level, greater than 22, a much higher overall survivor than the least fit in that group. A similar finding was identified in this study published in the New England Journal of Medicine, which looked at patients referred for exercise testing. And what they found is that every 1 MET increase in exercise conferred about a 12% improvement in survival. And this was seen in normal subjects and in subjects with cardiovascular disease. All of this leads to the notion that exercise is medicine. Regular physical activity and improved cardiovascular fitness reduce the risk of recurrent cardiovascular events, as much as our medications that we prescribe, aspirin, statins, and beta blockers. When do we start cardiac rehab? As I mentioned before, the first phase is in the hospital. Phase 2 starts a week or 2 after discharge and should begin with a careful history and exam, followed by a symptom-limited exercise test. This establishes a baseline level of fitness and helps to determine the maximal heart rate and allows one to determine or monitor for exercise-related symptoms and signs of ischemia or arrhythmias. Patients, of course, should be continued on their medications, which are generally going to include a beta blocker during exercise testing. The classes that exercise training, class B and C are class B are the low-risk patients. For example, cardiomyopathy patients with EF less than or equal to 30%, New York Heart class 1 or 2, no evidence of ischemia at rest or below 6 METs. Class C are a higher risk group, exercise capacity less than 6 METs. They might have angina or ischemic ST depression at a rate less than 6 METs. Class A are the apparently healthy, and Class D are patients who are too sick and should not be exercised, either patients with decompensated congestive heart failure or severe symptomatic aortic stenosis, for example. An outpatient exercise prescription takes into all these components into hand. The FIT principle, fitness, how often, intensity, what level of exercise should they exercise, time, how many minutes per day, and type, walking on a treadmill, for example. It's important to advise our patients to begin with a brief warm-up, which helps to improve blood flow to the muscles, stimulates vasodilatation, and probably does reduce the risk of myocardial ischemia provoked by the sudden strenuous onset of activity. The endurance phase ideally involves rhythmic motion of the large muscle groups, walking, jogging, running, swimming, and we should give our patients a goal, 30 to 60 minutes per session, ideally every day of the week, but 3 days a week is good as well. And the recommended intensity is determined by the baseline exercise test. Resistance training is also important to improve muscle strength. Intensity of exercise. Now, this is a concept best used, the Borg scale is the best example of how patients can quantify how hard they're exercising. So a score on the Borg scale of 2016 is between somewhat hard to hard, and that corresponds to about 40 to 80% of the heart reserve, which is an optimal level for exercise. Intensity of exercise, if they can't have a conversation, then that means that they're probably exercising a little too intensely. We'd like them to be a little bit below that level. And it's important to advocate a cool down period to get the heart rate and blood pressure down to normal levels. We have many patients who may not be referred to cardiac rehab, or when they go, they may not actually continue. So this has been a problem. The American College of Cardiology has made efforts to promote cardiac rehabilitation, and hopefully that's having an impact. Home-based cardiac rehab is something that's become very important during the COVID-19 pandemic, and it's gotten a boost with approval of virtual rehab by CMS. There's a lot of potential with the technology available to monitor patients' physical activity, nutrition, vital signs, and I think the future is moving towards a more virtual approach. Hopefully, still we'll be able to see our patients in person, because there's a lot of benefit to the observation and that one gets in an actual on-site exercise program. I think that's all my time. Thank you very much.